And now it's a great pleasure for me to introduce Dr. Samantha Mills, who will also be talking about tumor imaging, specific in gliomas. And Dr. Mills comes from the Walton Center, NHS Foundation Trust in the UK. It's a pleasure to have you here.
Thank you. Hello, can you hear me? Yeah, okay. Thank you very much for the opportunity to talk today. I was invited about 4 weeks ago, so this has been prepared very quickly. So it is a preliminary analysis of some of our retrospective data. So yeah, it's a retrospective analysis of our IDH1-Mutant Gliomas at the Walton Center. We're based in Liverpool. So we used the CirCare parameters here. So these are novel markers. We've heard a lot about cerebral blood volume, which is the usual one we get from DSC. I too normally ignore the blood flow. Reassuring for those out there that ignore that. On DSC, it's not very good. I use blood flow from ASL when I'm doing my perfusion analysis. So the aims of this study were to assess how the conventional marker rCBV would correlate with these more novel markers in a cohort of patients with IDH1-mutant gliomas in relation to particularly grade, histological subtypes, so we're looking at astrocytomas and oligodendrogliomas, and survival, because we've got a retrospective data of patients. It's quite historic, it's about 10 years old, so a lot of them have unfortunately passed away. We have a brain tumour bank at the Walton Centre in Liverpool, which means pretty much any patient that has a brain tumour is consented, their tissue and their imaging is all banked, so we can use it retrospectively for image analysis. I would encourage you to get your surgeons to sign up to something like this because it makes doing research really easy in the future. So we've got both oligodendrogliomas and astrocytomas. We process the historic DSC data using the CirCare oncology package. We've assessed the relationships between the individual parameters and grade and the histological subtype, and then examined the prognostic value of the standard and the novel perfusion metrics. So we started off with 40 patients. It is biased. I wanted to have 20 oligos and 20 astros, and I also wanted to make sure that some of them had passed away. So I made sure in each group, half of them had passed away. So I know there is bias in there, but there's bias there just to make the analysis a bit more easy to do. So they were selected for survival analysis and known outcomes of all of them. When you pull out these patients, unfortunately you find out only 31 of the patients had actually had DSC perfusion analysis, so we've lost 9 already. And another 2 were excluded because although they had DSC analysis, it was not temporally related to their histology. And it was about a year apart, so I didn't think it was going to be reliable, so we excluded those, which left us with 29. So we had about an equal split of male and female patients, and the age was similar between both the male and female patients, and it was a good age range of both groups. Equal split of oligos and astros thereabouts, and similar for sort of male and female ratios. Grade-wise, it turned out that one of the astros was a grade 3 and one of the oligos was a grade 3. So we can do a little bit of analysis on grade, but it is really confounded by the fact that the majority of our patients are grade 2 and we've not really got sufficient grade 3 tumours to do an accurate analysis on. So allowing for this, none of these parameters reach significance, and that includes cerebral blood volume, which is over there in the corner. And it's probably just because we only have 2 grade 3 patients, and it's just a sample size rather than anything else. Although leakage did, interestingly, prove to be significant, with the grade 3s having lower leakage than the grade 2s. I'm just ignoring that because I think it is just a number basis. But to show you an actual picture, this is our patient here. We've got our oligodendroglioma grade 3. There is some enhancement with it. We can see we've got elevated cerebral blood volume in it. We've also got elevated OEF, a little bit of elevated CTH in there as well. And our leakage in that one was low. But on the conventional rCBV, we would have been happily calling that a grade 3 anyway. But the OEF and the CTH are also slightly up. When we look at the parameters and subtype, so based on oligo and astro, we didn't actually find a difference between our 2 cohorts based on CBV. There's a little bit of a tendency, maybe, but not really. It failed to reach significance on either a parametric or a non-parametric test. We did both just to be sure. We did, however, find a significant difference with oxygen extraction fraction, and that was significantly higher in the astrocytoma group, and that was both on parametric and non-parametric analysis. And also CTH showed a difference between oligos and astros. And again, the astros had a higher CTH compared to the oligodendrogliomas. The other parameters, CMRO₂, COV, and leakage showed no difference between the two cohorts. Just to show you some images, on the top row, we've got a typical astrocytoma, T2 hyperintense on the T2 weighted imaging, non-contrast enhancing on the T1 post-contrast, but it is a little bit low T1 signal. It's got elevated oxygen extraction fraction and CTH compared to an oligodendroglioma in the right frontal lobe, which you don't really see on the T1 weighted imaging, doesn't enhance. It has no elevation of OEF or CTH. So prognosis-wise, about half our patients had passed away. So it gave us some good data for looking at prognosis, but it's a really long time interval we've got for some of these patients, up to 10 years. When we look at grade, we can see we've only got 2 grade 3s, but they did die quicker than the grade 2s, but not all of the grade 2s. Interestingly, with age, I split it into 4 categories, and it did reach significance with age, but you'll see that if you were in the category of aged 40 to 49, unfortunately passed away quicker than any of the other age groups. And it's probably biased in this because the older patients, those that are in their over 50 towards 70, have had that tumour for a long time. It's been low-grade and indolent. It's probably never going to do anything. The younger ones have been picked up probably at the time they're transforming, and that's why they've passed away quicker. Surgery type, biopsy and debulking, there was no difference in overall prognosis between the two. I haven't got the Kaplan-Meier for the treatment. We had an equal split array of radiotherapy and chemo-rad. A couple of patients had nothing. The patients that had radiotherapy alone did tend to die a little bit quicker than those that had chemoradiotherapy, as you would expect, usually because it's a palliative radiotherapy or they've not been able to tolerate the full course of chemotherapy. With regard to subtype, there is no difference between prognosis between the astros and the oligos. And this might be because we've collected this data for a very long period of time. And I've also introduced bias because I've ensured that half of my oligos and half of my astros have passed away. So there's going to be statistical bias in there. But the curves do separate in the middle, which would suggest that the oligos live a little bit longer. What about prognosis and CBV? We found in the oligodendrogliomas there was a significant difference with CBV, but it's counterintuitive. And those with a higher CBV actually lived longer. You can think about why that might be. Sometimes CBV, there's higher blood volume. Does it mean it's going to be more chemosensitive because you can get the agents in better? And certainly there are some thoughts behind the Avastin patients with pseudo progression. The fact that you get that contrast enhancement afterwards mean that the drug has got in there. It is a breakdown of the blood-brain barrier that makes it more effective. We found no difference between survival and oxygen extraction fraction in either group, and the same with CTH. In rCMRO₂, we did find a little bit of a survival advantage with regard to the oligodendrogliomas, but again, it's difficult to know whether that might be just confounded by our statistical analysis, and there was no difference in COV. And leakage, again, showed no difference. So summarising our overall things that we've looked at, grade, it's a bit confounded because we've probably not got enough grade 3s. Histological subtype, which I think is the most interesting here, is the difference between the oligodendrogliomas and the astrocytomas, and that relates to the OEF and the CTH. And the astrocytomas had higher OEF and CTH compared to the oligodendrogliomas. With regard to the survival, I think the results are again confounded because of the bias that's in the cohort that we've selected, and also there's probably insufficient numbers to really look at this properly. And they've lived for a very, very long time, which means they might have passed away from other causes too. There are some limitations with how we've done this analysis because it's a retrospective data set and all good studies should be prospective. As I've said, there's a lot of bias in it. We also have a range of scanners in our hospital. We have everything. We've got GE, we've got Siemens, we've got Philips. So it's a big range of data. So we've not got homogeneity there. It's very historical, and the histology is historical, some of which predates WHO 2021. So I'm relying on the fact that they've probably got the histological diagnosis right. And our data set, of course, is small with only 29 patients. But I think we can make some conclusions, and that's mainly relating to the OEF and the CTH, which is higher in astrocytomas rather than oligodendrogliomas. As to why that is, I think I need to think about that a bit more. Oligodendrogliomas typically have a more chicken wire-like, mesh-like network of vessels within it, but that doesn't necessarily mean they've got that capillary heterogeneity within it, that transit time. And it doesn't necessarily mean that they're going to have a higher oxygen extraction fraction. It seems the astros have a higher OEF. CBV in oligos showed a relationship to survival, but as I've said, I think that's probably a little bit confounded. And the survival's really challenging to look at in low-grade gliomas because they live for a very long time. And if you live for a very long time, when you die, it might not be because of your tumour. It might be because you have a heart attack, you walk out the hospital and get hit by a bus. You know, there are other causes of death in these patients, and especially in some of the older cohort we've got here. So it's not purely related to tumour, and we've not accounted for that. We need to do some more work, look at the other grades, increase our numbers, and look at other tumour subtypes. And the next step that I want to do is take in some GBMs and some grade 4 IDH1-Mutant Gliomas to see how these differ, as well as those that have been treated with radiotherapy. We've already heard a bit about radiation necrosis versus tumour progression, and that's probably a really important thing to look at. And I think I've probably caught up on time quite nicely for you.
Thank you for sharing these really nice data. Are there questions from the audience? There's one in the back.
Yeah, thank you very much. This may be a slightly unfair question because it's perhaps slightly different from your talk, but one of the things is non-invasive diagnosis of IDH mutation, which is could be very important. I was just wondering if you think there are any perfusion metrics that might let you distinguish between mutated versus non-mutated, say, grade 2 glioma.
I'm not sure about perfusion. You can, of course, do it with spectroscopy. If you can do your editing of your spectrum, and you can look for 2-HGG on your spectrum if you've got preferably a 3 Tesla scanner. We don't do that clinically. We have done it in a bit of research setting. But from a perfusion side, I'm not quite sure how the mutation status would alter your perfusion. It's the other physiological bits of the tumour that's going to do that, the angiogenesis, and that the higher grade features that are unrelated to the IDH cycle.
I was really fascinated also by your sort of thoughts about how, you know, your knowledge of what the vasculature looks like and whether, you know, a high blood volume tumor, you know, could actually sort of, you know, mean that it's well oxygenated. And I'm wondering whether, you know, in your statistical analysis or when you look at more tumor types, whether you could, because you'd think that if a high blood volume, if it has very heterogeneous flows, then that would probably be counterproductive, whereas if it had high homogeneity, so allow low RTH, it could be really efficiently oxygenated. So I wonder if you can make models of prediction that sort of, you know, pairs some of the parameters.
That's probably the way to go in the future, isn't it? But you need a lot of numbers really to power that. To get you.
Yeah, so we need bigger studies. But I was really fascinated by your findings. It was very interesting.
Thank you.
Thank you so much.